Thank you very much for the introduction and salam alaikum. It is really like this that I felt coming home as I was arriving tonight, and it was dark and I was tired and I didn't see anything. And in the morning, the sun raised and I saw the region here, and it was fantastic to be here. So it's a great honor to be here today. But now you could say it's totally boring what he wants today. He wants to talk about pathophysiology. We all know pathophysiology. What is he talking about? But what I would like to do with you is to talk about some new ideas evolving from the research from the last 3-4 years, and where I believe is a brilliant option for our patients with diabetes, for diabetes prevention, but also for diabetes care. And maybe the importance for diabetes care is even higher. We know all know this colleague. He has destructed and destroyed our professional life, our private life, had a serious impact on our patient with diabetes, because every second death because of COVID was a diabetes patient, and 80% of those who had a breakthrough due to the immunization were diabetes patients. So it was a very, very strong coincidence between insulin resistance and type 2 diabetes and COVID. We cannot explain everything between this, but it was the pandemic after the epidemic. And in our state, in Germany, we have a situation like this, that you see 540 people from Facebook, all the red ones will develop diabetes in the next 5 years. And COVID was a very strong driver. And I don't want to say that COVID was making diabetes, but due to the pandemic reactions, lockdown, social isolation, social quarantine, the people in Germany gained 6.9 kilogram of body weight. And this 6.9 kilogram of body weight has led to a 19% excess additional incidence of diabetes in 21 and 22. So from June 21 to June 22. And this is something we have to combat this over the next years with this big number of diabetes. But there's also a lot of hope on this slide, and these are the green ones. The green ones experience the same. They may even had COVID. They may had all the risk factors. They are obese and they don't are physically active. They eat the wrong things. And they never get diabetes. So if the green one walks through this door, you see him and you say, this is a metabolic patient, but he has a very good insulin sensitivity. And the difficulty is we cannot differentiate between the green and the red one. We have to wait until the red one gets diabetes to diagnose him and to treat him. And this is what drives me to understand pathophysiology better. This is a very old slide. It's about 8 years old, and it was one of our first tests for continuous glucose monitoring. And you see this young woman has a high normal A1C, and the purple line is glucose. And it's 2,800 times a day we measured glucose with the CGM device. And the green arrows means she's eating something. And what is the purple line? We don't see anything. There's no elevation, even if she eats a lot of carbs. And this is what we know today. We actually know from the technology, this is normal. A normal insulin resistance or a normal pathophysiological state without any risk of diabetes means a flat glucose curve. It doesn't mean if you eat I got this very nice lunch box today, and there were a box with nice sweets in it. And I actually loved the sweets. So it does not mean if you eat this sweet that the glucose is increasing and then it's going down over the next 2 hours. If you are healthy and good insulin sensitive, you have a flat glucose curve. But this is what we normally see. This is the father of this lady I just presented. And look at the father. He has actually a better A1C than the daughter, but he has a totally different glucose curve. You see, in the morning, it's fine. Then there is some elevation, and then you maybe breakfast, maybe lunch. Then in the evening, glucose is going down. This is a big difference. The daughter needs about 1% of her insulin the pancreas can produce to regulate blood sugar. The father needs about 80%. The A1C is better in the father's case because he's eating less carbs, but the father needs maybe 2 or 3 more years until he is diagnosed with diabetes. The difficulty is we don't find these people. But if we translate this pathophysiological finding into our clinical care, we have the difficulty to find this person. We cannot differentiate between the green and the red one, because this is the difference between the green and the red one. But the logical consequence for our guidelines in the future will be that we are not looking alone onto A1C. We have to look at the fluctuation of glucose, because constantly with a high amplitude and a high frequency having hyperglycemia is bad basically for the heart. And if you have constantly with a high frequency and a high amplitude hypoglycemic events, it's bad for the brain. So now you can choose what is better, what's more important, brain or heart. The goal of our therapy should be this: even independently from A1C, if you have two patients, both have the same A1C from 7, one has fluctuation of glucose like this, the other one, big one, this one will die because of a stroke and a heart attack. The other one may even never develop complication. If we now translate this into our pharmacological treatment, and we have to choose what drugs to use to lower the amplitude of glucose fluctuation, insulin is actually increasing the fluctuation. We cannot avoid insulin for our patient, but sulfonylurea are increasing the fluctuation. We can avoid sulfonylurea, especially with all the new oral antidiabetics which are coming to this region here or are available since years. It's becoming a very good option, but the perfect drug to reduce the fluctuation of glucose is metformin. The oldest drug, the cheapest drug we have. It's a very, very good option for our patient with diabetes. But the common soil behind both is the pathophysiology. And here you see 90 years of a patient developing of on the screen, I think the pointer doesn't work. So you basically see hyperglycemia is developing. There we have a differentiation with impaired glucose tolerance and diabetes. Here, hyperglycemia develops, but 20 to 25 years before, insulin levels increase from 1%. It's maybe here is the daughter I have shown you, and the father is positioned here. The father needs 80% of its insulin to regulate blood sugar. The daughter only 1%. The father is severely insulin resistant. And then there's pro-insulin precursor of insulin. If you measure pro-insulin in the bloodstream, it's like an acid in our vessels. It destroys our vessels. All this is transmitted by free fatty acids. But where are the free fatty acids coming from? They come from the visceral fat. It's basically the fat below the muscular layer in our abdomen. And why is this visceral fat so harmful? Because today we know there are more than 630 peptide hormones released from the visceral fat, and they act in the brain, they act in the muscle, they act in the kidney, they act basically in every tissue, and they make us getting sick. That means the presence of the visceral fat releases this hormone, and this increases our morbidity. But there is also this black guy, and this is a hepatic fat. This is a liver fat. If I was here in 2015, no one really was talking about liver fat. We said, oh yeah, liver fat exists, it's bad. But if it's present, you cannot do anything against it. You can remove the liver, yeah, then the fat is gone. And this is very interesting. There is, in the normal glycemic stage of the person, there's a certain period at about 40 to 45% insulin resistance, where suddenly the liver fat increases and then constantly stays high. Today, I would say the visceral obesity or the visceral fat is making us sick. The liver fat is killing us. The liver fat actually is killing our patients. So the logical consequence is to understand the interplay between visceral fat and hepatic fat better, because this is a common soil for basically all our common diseases we know. Here are two examples. I apologize if I'm offending someone. Both are my patients. And this one on the one with the subcutaneous obesity, he weighs 170 kilograms. So it's a very, very heavy patient. But he has better insulin sensitivity than I have. This is purely subcutaneous obesity in this case. But this one here, Yeah, he has a body weight of about 84 kilogram. He has a visceral obesity. And this difference between, everyone would think this is bad. Yeah, but at the end, this is bad. Yeah, these are two extremes. Yeah? Normally, the extremes doesn't exist in our routine clinical care. But the difference is highly interesting. Yeah, you can have 80, 100, 120, 150 kilogram of subcutaneous fat. Subcutaneous means wherever on the body you can touch the fat between two fingers. This is subcutaneous fat. And this has no meaning on endocrine level. It's not increasing your cardiovascular or endocrine risk. It's not totally like this, but this is easier to understand. The visceral fat is making us sick. So about 4.8 kilogram of visceral fat increases your cardiovascular risk threefold, increases your depression risk of 3.8-fold. As a man, if you have 4.7 kilogram of visceral fat, you have only 5% viable sperms left. So that means you are basically impotent because of the secretion of hormones out of the visceral fat. And the main driver of getting diabetes and insulin resistance comes out of the visceral fat. And why does it, or how does it work? Here you see the insulin signal transduction cascade. And you see insulin docks to the receptor, and all the white blocks are switched on or phosphorylated afterwards. And then at the end, glucose is the glucose receptors moving to the cell, and then glucose is incorporated into the cell. All the red substances come out of the visceral fat and block this process. This is the easiest way to understand insulin resistance. So the logical consequence is we have to do whatever we can to get the visceral fat away, and we have to do whatever we can to get the liver fat away. So now, I apologize to those who are in the virtual room. How can we reach both? How can we get the visceral fat away without asking the surgeon? The only way in getting visceral fat away is physical activity. Because if you are physically active, the visceral fat is releasing all these hormones, releasing the free fatty acids into the bloodstream. If the blood flows through a muscle where the muscle is moving, it initiates processes in the muscle to burn a little bit amount of fatty acids. And if you are physically active, let's say about walking 10,000 steps a day, within 2 weeks, you burn about 80 grams of visceral fat. So that's good. So 10 weeks is 800 grams. Yeah? It's a good opportunity with physical activity. But how can we get the hepatic fat away? We will come later to this. The understanding is this is the common soil for the development of basically all chronic diseases. And the problem is actually getting bigger. The liver fat, the presence of liver fat makes our patient to a non-responder or bad responder to our pharmacotherapy. So you give a GLP-1 or you give metformin. If the liver fat amount increases, you still give metformin, but the response is only 30% or 40% to the metformin by the increase of liver fat due to the secretion of hepatokines out of the fat cells in the liver. It's a fascinating process. Unfortunately, it's killing our patients. So if we look at the epidemiology, NAFLD is a commonly described term for liver fat. Many of our diabetes patients are affected as more obese they are, as more liver fat they have, as higher the A1C is, as more liver fat they have. And look at the last column, 8.5. It's nearly 80% of the patient having too much liver fat. They probably have the high A1C because of the liver fat. And this is very interesting because here we look at patients who have no liver fat and have liver fat and are non-obese or obese. And we see the obese person without liver fat has a much better insulin sensitivity than the slim person with liver fat. And if you're honest, we all know patients who are slim and they have diabetes, they have insulin resistance. Yeah? We all have seen them in our practice. And this is with a very, very high probability driven by the liver fat. And where is it coming from? It's coming from our behavior. Normally, I would ask who likes to drink Coca-Cola. Some people may raise their hand. Then I would ask who like, two honest persons. Who likes to drink a Diet Coke? And it would be good to stop this. Why? You see 380,000 patient years on this slide. And it shows if you drink, I apologize for the Jinglish in the title. Yeah, it means if you drink one drink per day for 1 year, so 365 drinks over a period of 1 year, what does it make with diabetes risk? If you drink water at the beginning, nothing with diabetes risk. If you drink orange juice, where the oranges are on the label but not in the bottle, it's 40% like a normal Coke, but the Diet Coke or Coke Zero makes 60% increase of diabetes risk per year. How can this be that the Coke without sugar is making more diabetes than the Coke with sugar? And the answer are the artificial sweetener. If you drink one Diet Coke per day for about 14 days, it changes your microbiome more severely than taking an antibiotic for 10 days. So the reason why the artificial sweetener are so harmful are because they are changing the microbiome. There are 13, and in Asians, 14 different bacteria. They are invading our gut. Well, we don't recognize, yeah, we still digest. But this bacteria, they love to eat this artificial sweetener. So they actually grow faster than E. coli. And what are they doing? They are producing fatty acids. So the bacteria we are feeding this artificial sweetener, they produce fatty acids. These fatty acids are the same as incorporated in our bloodstream, like eating the Egyptian dish. And they are accumulated in the liver. So we drink Diet Coke. We consume artificial sweetener, we grow the wrong bacteria. This bacteria produce fatty acids and they get us getting liver fat. And this is a disaster, yeah? Because the people do this because they want to live healthy, but they make the situation actually worse. So in here is actually the ultimate disaster, because if you consume artificial sweetener, you change your microbiome, you produce, the bacteria produce this wrong fatty acids, and this makes you becoming a non-responder to physical activity. And now this is actually a big disaster, because I told you to get the visceral fat away is only possible by physical activity. And now you have this liver fat, you have the wrong microbiome, you become a non-responder to physical activity. So you cannot get your visceral fat away anymore. And the devil's cycle starts, making our patient more and more obese. They're getting more and more insulin resistance, more and more higher A1C, and more complications. So stop this lifestyle. It's a photo on a lunch in Saudi Arabia. But if those people accumulate to our lifestyle, it's not easy to change lifestyle. And the final aspect is what we often forget. Our liver helps us to reduce insulin resistance, so with the hepatic insulin clearance. But this is diminished if the liver accumulates too much liver fat and cannot do this anymore. And I ask you, how can we get the liver fat away? And I didn't give you the answer. The answer is very, very simple. And it's actually the ideal process or ideal therapy here in this region, because it's fasting. If you fast for 2 weeks, and fasting means not eat anything, not the Ramadan style of fasting, it means a water diet for 2 weeks, or a 600 kilocalorie diet for 3 weeks. It's one study showing this with a 600 kilocalorie diet. There are 8 studies showing it for a 2 weeks 0 calorie diet. Because what happens after the 3rd day, you shift in a ketosis, the one what we fear for our type 1 diabetes patient. You are in a ketosis and the body mobilizes the ketone bodies. Ketone bodies have a lot of energy, are good for our brain, are good for our heart. And where is the body getting the ketone bodies from? From the fat. And it's very easy, or it seems to be very easy to mobilize the fat out of the liver, to mobilize the fat of the visceral fat. So 2 weeks fasting in a patient who is newly diagnosed with diabetes, diabetes disappears for the next 2 years. It's the fastest gain of health we can generate for our patients. And it's the fastest gain of health we also can generate for ourselves. So the remission of diabetes is basically in the answer in removing the fat from the liver. Since the last 1 year, there are studies looking in the fat in the pancreas. So the pancreatic fat, it moves probably in the same direction like the liver fat. But getting this fat away, we can generate a remission of diabetes for many, many of our diabetes patients. So here, normally diabetes starts. Here we diagnose diabetes, but if we are able to motivate our patient to fast here, we get the liver fat away, the hepatic fat away, and maybe we can stop the pathophysiology at the end. There's also a study showing that the high protein containing isocaloric diet reduces the amount of liver fat by about 40%. So it's an alternative, but the best option is always fasting. And I call it the water diet or fasting. And here you see an example. It's always bad to give yourself as an example. But here you see a scale from myself as I started after the Corona pandemic with 91.7 kilogram. What was the body weight after 2 weeks? So it works. Here you see I share my own blood results. And you see at the, here on this side, I apologize. Oh, I exceeding the time. I apologize. 3 slides. There is the hydroxybutyrat. So I was in a severe ketosis, and this is the bottom. This is the ground where you burn the liver fat. But interesting is also here vitamin B12. It was before the fasting normal, and it was 5-fold elevated after the fasting. And we couldn't explain it. Why is vitamin B12 going up if you fast? The answer is because it's mobilized out of the liver. It's stored in the liver. And so this is basically an approval that this works. Stop eating to fast, drink 5 to 6 liters fluid per day. The first and second day works, third and fourth day are heavy. Then you switch into the ketosis. Then it's fascinating to fast. It's a brilliant way what you learn about yourself. You have to be physically active. If you go to bed and fast, the body will mobilize your muscles. You can scale yourself daily if you want. There's no need to do this. It's the same as important how you break the fast after 2 weeks. It means first day 600, then 800, 1,000, 1,200 kilocalories. Drink for the next 4 days, even 5 to 6 liters of water. And then you have gained a substantial amount of health. But let's ask my daughter. What is my daughter saying if the father is fasting? He says he's not recognizable. He's a shadow of himself. He's unbalanced. He's not a full member of the household. He's rather sluggish decoration. And I would recommend to leave him alone and not disturb him. So it impacts your life, but what you gain is worth a lot. Is this enough? Of course not. Be physically active. Walking 10,000 steps a day prevents, next to fasting, basically any chronic disease. Walking 1,000 steps more as a diabetes patient lowers the blood sugar twice as much as metformin are doing. This is the recommendation. Don't trust your physician, trust your pedometer. Here you see the pedometer. Here you see 31 German physicians at a diabetes meeting. All are using the escalator. Airport in Doha, airport in Munich, airport in Dammam in Saudi Arabia, all at diabetes meeting. So for me, a clear yes to physical activity, a clear yes to fast to remove the liver fat, because physical activity removes visceral obesity, fasting, the hepatic fat. And with this, a yes to 10,000, I will say shukran, because if we use all this knowledge, we finally will walk away from diabetes. Thank you very much.